tracheostomy in the NICU or the neonatal intensive care.
Start again.
Because they weren't that was a gun. Hello, everyone, and welcome to the Global Tracheostomy Collaborative's webinar, Tracheostomy in the NICU or the Neonatal Intensive Care. My name is Diane Randall, and I am the patient and staff tracheostomy educator at Joe DiMaggio Children's Hospital. It is my privilege to introduce our expert panels for today's webinar. Dr. Bruce Shulman, he is the clinical director of the Neonatal Intensive Care at Joe DiMaggio Children's Hospital. He graduated from New York Medical College and did his fellowship with the Department of Neonatal Medicine at Babies Hospital in New York. Dr. Shulman is now leading his team at Joe DiMaggio Children's Hospital in the BPD Collaborative. Dr. Samuel Osterauer is the medical director of pediatric otolaryngology, head and neck surgery at Joe DiMaggio Children's Hospital. He graduated from Tech School of Medicine and did his fellowship in pediatric otolaryngology at Boston Children's Hospital. He is a GTC champion and is the lead of the tracheostomy team at Joe DiMaggio Children's Hospital. Dr. Larry Ryan is Chief of Neonatology at the University of Massachusetts Memorial Children's Medical Center. He is also board certified in pediatrics and pediatric pulmonology. He graduated from the University of Pennsylvania and has his master's degree in public health from Harvard University. He did his residency and fellowship at Boston Children's Hospital and Beth Israel Deaconess Medical Center. He founded and directed the Center for Healthy Infant Lung Development Program at Boston Children's Hospital and is currently involved in research related to long-term outcomes of neonatal lung disease. Dr. Karen Waters, who graduated from the University College of Dublin at the National University of Ireland. She is an otolaryngologist at Boston Children's Hospital and associate professor at the Harvard School of Medicine. And in the background is our technical expert, Haley Rayburn, who co-organized this webinar. So just for a few things, some of you have already submitted a few of the questions, and they will be addressed during the webinar. Other questions that you might have during the webinar can be typed in the text box, and we will be addressing this at the end of the webinar. This webinar is being recorded and can be viewed by members of the GTC. Other questions or information about the GTC, please go to www.globaltrach.org. If you're having any technical questions, please go to www.gotowebinar.com. Tomorrow, you will probably be receiving a post-webinar survey via email. So I think we're going to get started, but first thing I wanted to say is neonates are not small adults. For that matter, they're not even small children. They're a very unique group of patients that have very special needs. Introducing a surgical airway into this fragile group has its challenges. Our goal today is to tap into the expertise of our panelists. So for some of the learning objectives, we're going to be discussing preparing and educating the NICU staff team members in the care of these babies. Our surgeons are going to be discussing the exit procedure or ex utero intrapartum treatment. We're also going to be discussing airway conditions that can require a tracheostomy and how it affects other systems treatments. Lastly, we're going to learn about the advances and the treatment of bronchopulmonary dysplasia, or BPD, tracheostomy with BPD, and how a multidisciplinary team approach affects better outcomes. So we're going to be starting with preparing the NICU staff. So I'd like to start with Dr. Osterauer. Can you please share with us some of your ideas in preparing the NICU staff?
So thanks everyone for joining us. Over the past 2.5 years or so, we've embarked on a broad spectrum tracheostomy quality improvement project prompted by our membership in the Global Tracheostomy Collaborative, which started in 2014. Before we joined the GTC here at Joe DiMaggio, we had a relatively disjointed education program and protocols, if you will, for taking care of our tracheostomy patients, both in the NICU, in the pediatric ICU, and on the floor. There was no comprehensive protocols that were driving the care for these patients. And so, prompted by our membership in the GTC, we embarked on this comprehensive education program and quality improvement program. And I think it's important to understand, of course, where we started from without any real global strategy with respect to taking care of these patients, but also the lack of any go-to individuals or leaders or champions, if you will, for leading this effort. And that's one of the things that membership in the Global Tracheostomy Collaborative helped us with, which was just how are we going to structure this? How are we going to achieve our overall goal? And so it really required a lot in the way of institutional support. So we've got a very supportive administration who gave us the resources and actually elevated Diane Randall here into the position of tracheostomy educator and our quote-unquote trach RT person. And of course, myself kind of helping to bridge the gap between the units, the administration, and the patients. So it's also very important to understand that our approach and the overall approach that I think has been kind of led by the Global Tracheostomy Collaborative is a multidisciplinary approach to taking care of the tracheostomy patient. And that applies to the NICU, the PICU, on the floor, and in the community. But when we started this, we developed a standardized education program. And in large measure, that was designed and developed by Diane with my input and the input of other leaders in the hospital. But since we started, we've educated more than 300 individuals throughout the hospital and in the community. And these are all new employees who come into the institution, both registered nurses, mid-level practitioners, PAs and nurse practitioners, respiratory therapists, speech therapists, OT people as well. And we've been able to provide this by using CMEs. So that's one of the ways that we've encouraged individuals, not only the new employees who have mandatory training, but everyone else in the hospital gets CME credits for this education that we put them through. But the education program involves going over a binder of information that goes through the background for what a tracheostomy is, how it's placed, what's the pertinent anatomy, how to care for these in a routine fashion. We're going to get into some of the details here in a little while. How to appropriately process and clean the trachs, and how to manage emergency situations or near misses in these tracheostomy patients. And part of the education program is hands-on experience using the tracheostomy mannequins, both larger adult size and also the neonatal size mannequins.
Dr. Breen, can you tell us about your team at UMass Memorial?
Yeah, so I would say that I echo a lot of what was just said. I think that one of the key points is that we're going to learn a little bit about, in today's webinar, some of the data behind some of the practice management styles. But I think one of the great things about the GTC Collaborative and this concept of standardizing the care is not so much exactly the specifics of the protocols as much as a focus to developing those protocols for each discipline. And so having that kind of structured approach, it was a recent move for me here to UMass from Boston Children's, where we did a lot of work together in trying to standardize things both through the GTC Collaborative and through the Tracheostomy Clinic program. And so here it shows, I think, work that is yet to be done, that can be done when you use a structured, standardized approach for all the different disciplines that are involved in the care here. So as I came to UMass and we're already even growing our tracheostomy population, you can see the need for these structured programs and guidelines at every level. So for our respiratory therapists, for our bedside nursing staff, even for the multidisciplinary physicians involved in the care, both inpatient and outpatient. And so we're working with the GTC and with some of the materials that we worked with at Children's to develop those structured guidelines through all the different disciplines.
Okay, great. Thank you. Dr. Schulman, can you talk to us about some of the reasons for keeping neonates in the neonatal intensive care?
From our perspective, the one thing that we've come to realize is that we have more gaps than knowledge in this field. There are no good prospective studies that tell us when or who needs a tracheostomy. And one of the things that we are finding with our kids is that, as we, in our unit, as we deal with a lot of our extremely low birth weight infants, and they progress and they stay on ventilators for prolonged periods of time, we've come to realize that if we're going to optimize their care, environment that's friendly to development, environment that allows them to develop as people without being tied to a machine and an unstable airway is key for their long-term outcome. And I think, we are the advocates for these kids since we've taken care of them from the beginning. And we are, certainly, though a lot of units send their babies to the PICU and transfer them out at certain ages based on bed census and availability of resources. We're lucky and fortunate here to have the bed space and availability of resources that we can keep them here. But certainly, the ability to care for the infant, regardless of geography, is dependent upon having an understanding that we know. What we don't know is more than what we do know, and it's regardless of where we keep these kids. We need to understand that we need to think of them as an entire person. So there's just a lot of things that we could do elsewhere, but we decided to here based on resources. I think no one should be restricted by a wall about where they care. As long as these kids are getting good comprehensive care, I think we can care for them equally in a PICU or NICU, but in our institution we decided NICU because of availability of our resources here.
Thank you. Dr. Osterauer, I think you covered a lot of this before. The standards of care, the safety equipment, I think we kind of talked about that.
We have. I'll just add on, in the interest of time, the fact that in addition to the broad-based education program, which does involve parents and families, that we've implemented a multidisciplinary team rounds program, as I know a lot of the member hospitals have done. But our team rounds involve the otolaryngology service, neonatal or pediatric ICU medical staff, including physicians and mid-levels, nurses who are taking care of the individual patient with the tracheostomy, our primary respiratory therapist for the trach, which is typically Diane, as well as the bedside respiratory therapist, as well as speech therapy. And we go through, it's a classic rounding type of a scenario where the patient is presented starting with the medical problems, but we focus on the trach and the diagnosis related to the trach. We go through vent settings, the type of trach. We verify that all of the necessary bedside equipment and emergency trach supplies are always available and ready, and that the head of bed sign, which indicates the type of trach, whether it's a custom specified length of the trach as well as diameters, and to what length the patient should be safely suctioned. We use minimal suction technique with measured suction technique to ensure that the trachs are not being suctioned too deeply in an effort to reduce complications such as granulation tissue and tracheitis and bleeding related to the trachs.
Okay, thank you, Dr. Osterauer. We're going to be moving on to the exit procedure, or the ex utero intrapartum treatment. And we're going to rely heavily on the surgeons for this one. And I think I'm going to actually have Dr. Waters talk about this because she has actually been in attendance. So Dr. Waters, can you start to tell us about it, please?
Yeah, so first of all, I'd like to say that really the exit procedure came around following our advances in prenatal ultrasound and MRI. They've significantly improved our ability to diagnose upper airway congenital abnormalities in utero. And this thus allows us to properly assess the airway and plan airway management prior to the delivery, preventing any unexpected problems at the delivery itself. It's interesting, when we think about the exit procedure, it was initially first developed actually in the early 1990s to remove tracheal clips placed in utero to treat fetuses with severe congenital diaphragmatic hernias. And it provided such an optimal controlled environment to reverse the tracheal occlusion while receiving urethral placental circulation. So I'm going to talk a little bit about the indications. So exit procedures, its indications have since expanded, and it's usually recommended for fetuses with upper airway obstruction, usually caused by a giant neck mass, for example, such as a cervical teratoma, lymphatic malformation, or a fetal airway obstruction can also be secondary due to intrinsic defects of the larynx, such as laryngeal webs, laryngeal cysts, laryngeal atresia, and tracheal atresia, and also intrinsic bronchopulmonary issues such as bronchopulmonary sequestration. The exit procedure really involves a medically induced uterine relaxation, which preserves the ureteroplacental circulation, allowing for maternal fetal bypass as such. Next slide. The success of an exit procedure relies heavily upon the assembly of a multidisciplinary team and pre-procedural preparation. And the importance of this really cannot be underestimated. The exit team should include obviously the obstetrician, maternal fetal medicine, neonatology, usually an otolaryngologist, a general pediatric surgeon, and at least 2 anesthesiologists, as well as circulating and scrub nurses. And coordination of all the team members requires rehearsals in the operating room prior to the planned procedure. Everybody should be aware of their role, the operating room layout, and equipment. And when we're usually planning an exit procedure, we normally have a number of meetings prior to the procedure to define everybody's role. And we also usually, usually, if possible, have the mother comes over to our children's hospital, and we have 2 operating rooms side by side, one set up for the delivery and one set up to bring the infant to once they are born. The exit procedure should typically be scheduled as close to term gestation to avoid problems with prematurity. And there are risks to the mother as well, including uterine atony, placental abruption, and also severe hemorrhage. So I'm going to talk a little bit about the actual procedure itself. First of all, the mother is induced via rapid sequence, intubated and then maintained on inhalational anesthesia. And then the exit procedure itself initially involves delivering the fetal head through a well-controlled hysterotomy and managing the airway while fetal gas exchange is maintained with the placenta. And usually you get an average of about 45 to 60 minutes. And this is actually in stark contrast to a C-section, whereby the major goals are to minimize the time from anesthesia to cord clamping and decrease the exposure of the fetus to the inhalational anesthesia. Next slide. So I have a few images here of an exit procedure. So as I mentioned, a low transverse hysterotomy is first performed, the fetus is exposed, the head and shoulders are delivered, and on some occasions a fetal extremity, an arm, can actually be delivered enough that you can actually apply a pulse oximeter probe in it and obtain intravenous access. The fetus at this stage can also be administered other anesthesia and paralytic agents as well, if necessary. And obviously, again, the coordination between the surgery, obstetric, and anesthesiology teams is absolutely paramount to prevent excessive maternal hemorrhage, because the uterus is usually completely relaxed at this stage. Next slide. As I said, we get usually about 45 to 60 minutes, and this usually gives us enough time to attempt a direct laryngobronchoscopy, intubate the patient. If this is not possible, it may allow us to resect part of the neck mass to secure the airway via tracheostomy. Next slide. So here are some live images. So this is a fetus being delivered via exit. The top of the slide are the legs, at the bottom is the head. You can see the ENT surgeon has placed a direct rigid bronchoscope in an attempt to find the airway. Next slide. Unfortunately, it wasn't possible to secure the airway, so a decision was made to proceed with an open tracheostomy. And you can see that they are defining the anatomy in the neck and making the incision. Next slide. So here we can see that the tracheostomy has been placed, its position is being confirmed. And once, next slide, and once the tracheostomy is secured and everybody is happy, the umbilical cord is then clamped and the delivery is complete. The baby, next slide, the baby is then taken either to an adjoining operating room for further evaluation or assessment, or if they're stable, they're taken immediately to the NICU. And again, you can see from this image that the coordination of all team members, both on the obstetrics, surgical, and neonatal side, is really of great importance. Next slide. I think that's it for this page.
Okay, thank you. I think what we're going to do is we're going to have our other otolaryngologists talk about upper airway abnormalities. So Dr. Osterauer, can you go over some of the either congenital or acquired upper airway abnormalities?
Certainly. So with respect to tracheostomy in the neonatal ICU or in neonatal ICU patients, the relative proportion of these patients requiring trach among all patients who are trach in the ICU has gone up somewhat because of improved care of the BPD and chronic lung disease in these patients. So the incidence of these patients has not gone up, but the relative frequency of tracheostomy compared to all tracheostomies in the neonatal ICU has gone up. But a large number of the congenital problems oftentimes relate to, and these of course are the patients who we don't think are going to require an exit procedure. So a lot of the craniofacial dysostoses, such as Goldenhar-Cruzon, Apert-Pfeiffer syndrome, with either very small midface or small mandibles who have airway obstruction related to the skeletal abnormalities, and oftentimes will require tracheostomy if we are unable to either intubate or once they're intubated, if we're unable to successfully extubate them. It should be noted that patients with Apert and Pfeiffer syndrome sometimes may be able to maintain their airway related to their skeletal abnormalities, but these patients have a relatively high frequency of laryngotracheal abnormalities, such as complete tracheal rings or sleeve trachea. So always keep that in mind, of course, when you're dealing with some of the craniofacial abnormalities, that they may have laryngotracheal issues as well as their skeletal problems. Next slide. In addition to the skeletal dysmorphisms and congenital lesions, laryngotracheal stenosis, as we all know, has been an issue for many years in the neonatal ICU. It was worse, of course, in the 70s and 80s when rubber endotracheal tubes were used and the tubes were not managed as well. But the incidence of laryngotracheal stenosis overall has gone down in the neonatal population, in part due to improved non-invasive support for these babies and the ability to get them extubated sooner. But acquired laryngotracheal stenosis continues to be a significant issue. Tracheomalacia is oftentimes an issue with our cardiovascular patients with atypical vascular anatomy, tracheal rings, this sort of anomaly. And tracheoesophageal fistula patients also fall into this category due to their incidence of associated tracheomalacia and airway collapse. Next slide.
Okay, thank you. What we're going to do now is we're going to move on to BPD. It's really the lower airway conditions that actually would require a tracheostomy in a neonate, specifically bronchopulmonary dysplasia. And for these slides, I'm really going to rely on our neonatologists for this. So, Dr. Schulman, can you talk about some of the new modalities that have been featured for BPD?
As Dr. Ostro was mentioning, the incidence of tracheostomy related to bronchopulmonary dysplasia is small, and in large databases, you're looking at, depending upon, if you're looking at an overall population, anywhere from 0.5 to 2.7% in all babies getting tracheostomies. If you break them down into under a kilo and over a kilo, the percentage over a kilo can sometimes go up anywhere from 2.5% somewhere to 6%. But overall, we're still looking at a very small amount of babies who end up needing this procedure, and that is because of our care practices that have been developed over these last decade or so. In particular, anti-native steroids, the use of surfactant, use of primary care mode of non-invasive ventilation, be that CPAP, nasal prong ventilation, the avoidance of prolonged intubations, the correct endotracheal tube size, good nutrition, have all led to earlier extubations and or not intubating these babies, and also using non-invasive means of administering our surfactant now with what's called the INSURE technique or MIST techniques, minimally invasive strategies. So we have done a great job at preventing the development of BPD through our techniques using both high frequency, and if we do need to go on ventilators, using gentle ventilation techniques, permissive hypercapnia, and if needed, high frequency ventilation. And we've become very good at that. That is always our key to prevent BPD. Yet we're still left with a core group of babies who unfortunately have prolonged intubation and prolonged respiratory needs, and unfortunately also end up needing some form of stable airway despite these preventive needs. But again, the overall BPD rate has diminished. Most units can bring it down, below, in general, into the teens, sometimes even less than that, using these new techniques. But we're still left with a core group of babies who do need the help of the tracheostomy.
Okay. Dr. Ryan? Can you talk about this?
I'll talk a little bit about that small subset that was just mentioned. So even with all these improvements, there are going to be a small percentage of babies who do have such severe lung disease, either because they were born so prematurely, and so with the improvements in care, we're seeing improvements in survival with some of these morbidities. And then there's some of the comorbidities of a long NICU stay, whether it's acquired infection or whether it's inherent factors. And so there's going to be a small percentage of babies that continue to have need for prolonged ventilation. And so the question is, when can we determine the best time to place a tracheostomy in such patients? And it's controversial. I think the issue is that for many of our BPD patients, one of the ways that we, as I just mentioned, that one of the ways that we try to prevent later lung disease is by minimizing ventilator exposure and by doing permissive hypercapnia. Unfortunately, there becomes a time for some of these babies when that approach clearly isn't effective. And then what happens is that we have to have a shift in our process from permissive to higher CO2 levels and lower oxygen levels, but making a shift to allow improved development. And so the issue is that for those babies that need prolonged ventilation, what's the most developmentally appropriate method to deliver that, and that's through the tracheostomy. And so the ability to provide that long-term ventilation in a more developmentally appropriate manner through the tracheostomy allows the child to do lots of different things that are more developmentally appropriate in terms of being more mobile, in terms of being more interactive with their parents and caregivers. And so the timing of tracheostomy is controversial. There's growing data behind us. Next slide. Again, the most common indications for tracheostomy are really the need for long-term ventilation, and there's several studies that suggest that if we provide tracheostomies earlier, we could potentially improve neurodevelopmental outcome, because if we are providing without the tracheostomy, we're limiting the child's ability to interact with their environment, and so we have to at the timing of that tracheostomy. And so really the best determination of when that timing should be is when it's safe to place size tracheostomy, when it's clear waiting longer for a child to potentially wean off positive pressure ventilation is not going to be developmentally appropriate.
Okay. Dr. Schulman?
I agree with what Dr. Ryan said. There's a couple other points I'd like to make. One is that babies who have severe PPD and associated comorbidities who may need trachs may not be intubated at the time of their evaluation. You may find these babies who have severe pulmonary hypertension, who have very marginal respiratory reserve, and may be breathing adequately on CPAP, maintaining their ability to exchange gas, but with minimal ability to handle any stress. And these babies are a special subset that you may have a baby on non-invasive support, but his pulmonary hypertension has developed as a consequence of severe DPD, and those babies sometimes as well, even though they're not intubated, end up needing tracheostomies. The other point I'd like to stress is that there's uncertainty about the safety of performing tracheostomies in some of these small babies who are on high settings, high pressure, high MAP, high FiO2. There's some reluctance sometimes to say this baby's stable enough to go under a tracheostomy. I think there's some data that's coming out from some of the BPD collaborative sites, in particular nationwide, that looked at that, and actually they were successful at performing tracheostomy in babies who had average MAPs of 14, PIPs about 40, and FiO2 at 50%, and they were able to successfully trach these babies. So again, the level of support should not be the determining factor of when this baby needs to be trached. Both be that in a non-invasive mode, you may need to trach a baby because of pulmonary hypertension or associated comorbidities, or the level of respiratory support should not limit you when you need to trach this baby. There is a downslide of risk-benefit where this baby needs to get off sedation, needs to interact with the family, needs to develop developmental skills, that the longer you keep this baby in a sedated state or a limited state of movement, your return of neurodevelopmental impairment increases. Some studies, one of the Minnesota groups looked at that, and they had 65% poor neurodevelopmental in these kids on follow-up. And so the big picture then becomes important. Unfortunately, as we know, there's just no good data to tell you what the exact date should be, though the 120-day cutoff point seems to be something that has been published and people are looking at.
Okay, thank you. Dr. Rain, can you talk about some of the comorbidities?
Yeah, I think that one of the points that was just emphasized is one of the critical ones, which is that it's not just babies who require prolonged ventilation, it's babies who require prolonged respiratory support that supports growth and developmental behavior. And that can be not just mechanical ventilation, that can be CPAP. So any of these therapies that are required to allow the baby to have enough reserve to develop appropriately, if those are required, that's the indication for tracheostomy. And the issue is that with some of the comorbidities that are associated with severe BPD, we may need to ventilate these babies or provide the appropriate care in a way that is less permissive and is a little bit more aggressive. So in other words, when we treat most babies with BPD, we might allow their carbon dioxide levels to be a little bit more elevated. We might allow their oxygen saturations at the right gestational age to be a little bit lower. But if these babies with severe BPD also have the complication of, for example, pulmonary hypertension, those are babies that really, instead of being more permissive, that may be acceptable, but it's certainly not optimal. And by providing a tracheostomy, we can provide the ventilation that they require to improve growth, some of these other morbidities like pulmonary hypertension. The other thing that I mentioned is that some of the other comorbidities that go along with severe BPD may need to be addressed in order to help lung disease. So, for example, severe reflux is something that addressed and may be a contributing factor to the lung disease. And by supporting the child with the appropriate ventilation, slide.
Okay, next slide. Okay, there you go. Okay.
In terms of once the child gets a tracheostomy, it allows the shift so that the focus is not weaning from respiratory support, but optimal respiratory support and allowing us to focus on the other developmental and growth aspects of the child. Issue, it allows us to focus on better developmental outcomes. And so by focus respiratory support, providing adequate respiratory support neurodevelopment, going to lead to better neurodevelopmental outcomes.
Okay, thank you. These are some of our references. Haley, I think you're in the background now. Have you gotten a lot of the questions from some of the attendees?
Hi, Diane.
Hi, Haley.
We've gotten one question so far. So
Okay.
if anyone wants to send in more questions, that would be great. But I'll post it right now.
We can't see it, Haley. Can you do me a favor and can you read it for us, please?
Sure. The question is, it comes from Michelle, and it says, for Dr. Schulman, standardization and education efforts like you described, of course, need money. What kind of process, measures, and outcomes are being tracked as new interventions and tried and implemented that could support others in convincing hospital leadership to provide these resources?
Could you repeat that
question, please?
Okay.
So
Can you repeat that?
standardization and education efforts like you described, of course, need money. What kinds of processes, measures, and outcomes are being tracked as new interventions and tried and implemented that could support others in convincing hospital leadership to provide these resources?
So I think your question is more in pertinence to, at least for us and our involvement in the Global Tracheostomy Collaborative, is related to the REDCAT database as part of the Global Tracheostomy Collaborative. The individual who, I don't know if the individual who wrote the question is part of the GTC, but the GTC, part of it, as well as helping to promote good best practices and protocol development and multidisciplinary care, is a data collection effort. And so we all are entering data preoperatively and postoperatively on our new tracheostomy patients. We here at Joe DiMaggio, we don't have a very high volume tracheostomy practice. We're doing between 10 and 20 trachs a year, and we've only been members of the GTC for a couple of years. So we don't have a huge N at this point, but it's enabling us to track things such as any morbidity related to the tracheostomy, of course, mortality and the sources for those issues, It allows us to track our length of stay, as well as all of the associated pre-op and post-operative diagnoses and demographics related to the patients. So, I mean, we here have seen a reduction in our length of stay thus far, and as we move towards tracking our patients beyond the hospital, the hope is that we're going to see significant reductions in our morbidity and mortality that we can assume is related to safe best practice and good education for the caregivers. So that would be my kind of recommendation in terms of how these types of programs can lead your hospital leadership to get on board and support multidisciplinary care and support the human resources needed. And the GTC, I expect, is going to be publishing, as well as the individual institutions, publishing their data as more time goes on.
Dr. Ryan, do you have any other input to that as well?
I was going to make a comment that I think that standardizing the care of these patients is the right thing to do. It improves the care for the individual patients. But I think in terms of the question and how can we demonstrate cost savings, there's another aspect to this. I know that the folks in Denver, for example, I think published some work on their development of their structured tracheostomy outpatient program and how it can decrease hospitalizations. And Jay Berry has done a lot of work looking at rehospitalizations in tracheostomized patients. And I think that there's cost savings, not just in the sense that there's improved outcomes for these children, but when you think of it from the hospital perspective, when these patients get rehospitalized, by definition, often they're hospitalized back in our ICUs. And those ICUs are beds that are desirable for elective surgical procedures and for high turnover. And when instead they're taken up by potentially preventable issues, if only we had good standardized management like the kind that's being taught through the GTC, I think that that is an element of cost savings for the hospital system that should be exposed. And I think that it's a little bit of addition by subtraction, because for the individual patient, it may not show savings, but I think it helps the system so that the hospital can open up those ICU beds. So I would mention that that's one outcome that I'm glad that the GTC is continuing to look more at outpatient outcomes as well, not just the pre-discharge standardization, but those outpatient outcomes, because I think that's where a lot of the cost savings can be shown.
Dr. Waters, what are you doing up at Boston Children's?
Yeah, so I just really have 2 points to make along the lines of Sam and Larry. Firstly, when we implemented some of the key drivers from the GTC, the first thing we did was we implemented a specific tracheostomy adverse event category. So we've really kind of focused on reviewing our adverse events, and we have a closed loop system as such. And initially, it's interesting, once we introduced this category, we initially found an increase in the number of adverse events. But over time, for the last 2 years or so, we have seen increased reporting, but a decrease in the severity of the events, the tracheostomy events that are happening at our institution. That's the first point. The second point is along Larry's point about trying to see if multidisciplinary care is decreasing the ER attendances and the ICU admissions on these complex patients. And we've also set up a multidisciplinary tracheostomy clinic, and we're really closely now tracking the, should I say, interventions as such that are happening at that clinic, and following these patients to see that if them receiving multidisciplinary care at this clinic and greater access to their, should I say, trach providers, is decreasing their ER attendances and their ICU admissions. I think all of these, in pediatrics, there's no real tracheostomy metrics out there. They're very different to the metrics that are in the adult tracheostomy population, such as in the adults, time to decannulation is the most common metric. They don't exist in the pediatric population. So I think development of these tracheostomy-specific metrics in the pediatric population is really in its infancy. So hopefully over the next few years, with us collecting this data in the GTC and us getting our, we get twice a year reports whereby our institution is compared to a like pediatric institution, that it'll show us some hopefully better data that what we're doing is helping to improve the outcome of these patients.
Okay, great. Were there any other questions? Haley, have you seen any other questions come up?
No, there are no other questions.
There's no other questions. Did any of the other physicians want to add anything else?
I mean, I think I'll add, just related to the conversation we're having right now about outpatient-related complications, hospital readmissions, ER visits. We've extended our education program into the community to our chronic care pediatric vent facilities, so that all of the kind of the intensive education that we've given our healthcare providers in the hospital, we've provided to these facilities, these outpatient facilities as well, so that they are better equipped to deal with issues that might help to prevent sending these patients back to the hospital by, implementing measured suctioning. We will hope to reduce the incidence of trach granulomas and airway obstruction, hemorrhage, and tracheitis. And some of that certainly remains to be seen, but that's one way that we here have tried to extend the education program to reduce outpatient morbidity.
Dr. Ryan, there was one question there. Do you have a multidisciplinary clinic for your trach patients that have BPD?
We do, yes. And so we definitely have a multidisciplinary program for patients with BPD, and a subset of those go on to require tracheostomy and chronic vent support. And following that model and the model that was based at Boston Children's, we're developing a multidisciplinary tracheostomy program as well. And one key point that I wanted to make about these multidisciplinary programs that I think we didn't emphasize as much is that the parents themselves of these families, play an important role in assisting in these efforts. And I think that through the GTC and through the clinics that I've been a part of at Children's and here, I found that that's been a very helpful part of rolling out the educational materials, of determining what are the different needs out there in terms of what needs to be taught both inpatient and outpatient, what are the things that we should be following on an outpatient basis where those needs are. So having the families themselves, the families who've experienced a tracheostomy in their neonate are a tremendous resource as well, and they've added a lot, I think, to all of our programs.
I think that there's some more questions for Dr. Waters. Haley, can you read those for us, please?
Absolutely. So for Dr. Waters, how do you define trach adverse events at your organization?
So we've actually categorized them. We've actually set up a subcategorization. So it basically includes every adverse event, whether it's a nursing event, whether it's a trach supply event, whether it's a communication event, whether it's a surgical event, or whether it's an event that occurs during teaching. So I'm just saying this off the top of my head, but we have just recently set up a specific classification system. So when we get a monthly list of all the tracheostomy events that happened in the previous month, we're now actually categorizing them into these different categories. So it's anything related to the trach, whether it was a nursing, as I said, a supply issue, the wrong-sized trach was put in the patient, a decannulation, a wound problem. It encompasses everything that may be defined as a tracheostomy adverse event.
Okay, thank you. I think that we may actually end up ending a little bit early. We really thought that we would have more questions. I would really like to thank all of my panelists for their expertise, their insights, and their very valuable time. I'd also like to thank Haley for her technical abilities in putting this together. But I mostly would like to thank all of you attendees for your interest in the webinar, Tracheostomy in the NICU. If you have any questions about this webinar or future webinars, please go to www.globaltrach.org and have a great day. Thank you.